SAGES stories.
Welcome to today's episode of SAGES Stories, the official podcast of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. Please make sure to hit the like button and subscribe so you can stay up to date with our most recent episode. And enjoy the show.
Welcome back to episode 36 of SAGES Stories, where we shine the light on some of SAGES' most impactful leaders. I'm Kevin.
And I'm Jenny. So today's episode is a first for us. We're welcoming a pediatric surgeon to the SAGES Stories. Yay!
Yay, kids. Our guest is Dr. Bethany Slater, who is an associate professor of surgery at Mount Sinai and division chief of pediatric surgery at the Kravis Children's Hospital. She trained at Stanford and Baylor, Texas Children's, previously served on faculty at the University of Chicago, and brings a deep portfolio in minimally invasive pediatric surgery, clinical innovation, and surgical education.
She also chairs the SAGES Guidelines Committee, which means that she helps orchestrate the development of many of the clinical practice guidelines that you may have seen on our website and that many of our members rely on. So we'll explore her journey into surgery, pediatric surgery, I guess pediatric minimally invasive surgery, and then dig into a little bit of the how and why of the guideline development process. Welcome to SAGES Stories, Bethany. We're so thrilled to have you.
Thank you so much. I'm really thrilled to be on the SAGES Stories. Thanks so much for having me.
So we all start a little orientation. So a BA in biology from Columbia College in New York, where you now are back, and then Mount Sinai School of Medicine General Surgery residency at Stanford with a postdoctoral research fellowship. And then, as mentioned previously, pediatric surgery fellowship at Baylor in Texas. So you've kind of jumped all around the country. You have spent time in multiple regions and time zones. You're board certified in general and pediatric surgery. And just to add to your portfolio, you earned an MBA from the University of Chicago Booth School of Business. And you've had leadership roles across APSA, IPEG, and SAGES, of course, including the SAGES Guidelines Committee. Quite a journey, just to sum it up in 30 seconds, Bethany, quite a journey.
Thank you.
So we always like to start at the beginning, though. And so why don't you just start by telling us a little bit about yourself, where you grew up, and what first put medicine or even surgery on your radar?
Yeah, sure. So I grew up in New York City. I was lucky enough to have two parents in medicine. My father was a general surgeon at Mount Sinai, and my mom is a radiologist. So I've always sort of seen what medicine meant to them and been around it, and had always wanted to go to medical school. And while in medical school, really was introduced to surgery, loved being in the operating room, loved learning about the pathology, and definitely, although I was trying to keep an open mind, definitely knew I wanted to go into surgery pretty early on.
How did your mom take that, being the radiologist? She probably was like, come on.
Yeah, she didn't love it.
She didn't love it? I can imagine she didn't love it, huh?
She was happy that I was interested in whatever I was interested in, but I think she would have preferred radiology.
And what was it about surgery that, kind of made you think, oh, this is it. This is what I want to do?
I think the pathology, just the diverse different aspects of seeing the disease processes, and then the hands-on nature of operating room, the kind of culture being in the operating room, being able to diagnose something and then operate, and then hopefully patients improving afterwards. We see that a lot more with peds than necessarily all the adult fields, but it's just feels very impactful to be able to help someone and to actually be able to be so involved in the care and actually fix a problem.
Yeah, I love that. Actually, it's funny. So like as one of the minimally invasive surgeons, I've started inheriting a lot of adult pediatric patients. So I definitely acutely feel how special and different that community of patients are and how deeply connected they are to their surgeons. Because I think, they kind of grow up with their surgeons, especially for some of the kids who've had multiple operations or who have, maybe chronic conditions that need ongoing care. So I'm really like humbled to think about that process. And I think that's definitely very different. And as our first pediatric surgeon guest, and for those SAGES members who mostly operate on adults, can you like tell us a little bit about, what are some fundamental differences in pediatric surgery and specifically pediatric MIS, things that we probably don't remember from medical school, like technically, physiologically, or maybe even culturally?
Yeah, I mean, I think there are a lot of differences. I mean, first, just the operating room environment, particularly with our neonates, it's really important to keep the rooms really warm. I think that was one of the things that I realized it was really good for me to become a pediatric surgeon because I really didn't like being in a cold operating room, and it being really warm in the OR is really nice for me. But it's really important to keep the rooms warm because they lose a lot of heat. Neonates can't regulate their temperature the same way. So there are, a lot of differences, even, things like blood transfusion, how much blood you give, medications, all that kind of things is a little bit of a different physiology that you need to keep in mind, and some of the preoperative measures, particularly with the congenital anomalies. There are a lot of associated, for instance, congenital anomalies are associated a lot with cardiac anomalies. So, all these patients need an echo, things of that nature. That's, a little bit different. I will say though, operating on peds is really, really fun. I mean, there's typically not as much, fat intra-abdominally and extra-abdominally as well. The planes are really nice to operate in, particularly, again, the neonatal cases. It's just really, really lovely dissections that, even kind of cauterizing a duodenum, you can do a lot of that operation just bluntly. And it's really, really lovely to do.
Yeah.
So, oh, go ahead. Go ahead, Jenny.
Oh no, I was just gonna say, like, when we were looking at your CV, we kind of looked at some of the things that you were doing specifically on minimally invasive approaches across sort of pediatric surgery. Can you talk a little bit more about that? Do you think that really differs in pediatric patients versus adults? Like, I feel like it's been a while since I've done my pediatric surgery rotation, so maybe give us a refresher.
Yeah, so I'd say a couple of things. First of all, as pediatric surgeons, we still operate all over the body. We do thoracic cases, we do abdominal cases, oncology, congenital anomalies. So, we really do a really diverse, different types of operations. Um, and then, the congenital anomalies are something that's very different. So, for instance, like a tracheoesophageal fistula, where there's a connection between the airway and the esophagus. Those are type of things that you're not going to see in the adult world, unless it's iatrogenic injuries. So, they're really interesting things, rectal anomalies that we do pull-throughs for, just a lot of really interesting pathology. But, we see something different all the time, again, different ages, different pathologies, but there can be cases that we do that, someone even in the later ages of their career have never seen before. And that happens not that uncommonly. So it makes it, very interesting, keeps us a little bit on our toes always, but innovation is really important because, sometimes they have no choice. You have to kind of figure out what to do while you're in the operating room. Also, a lot of the devices are not made with a pediatric indication. So there are times where we need to sort of adapt adult procedures or adult devices to make it work in our pediatric population.
So actually, I want to build on that a little bit because you've done a lot of work in practice and innovation, specifically across the pediatric GI system, cholecystectomy, appendicitis pathways, biliary axis, abdominal wall, much more. So which clinical areas have changed the most in your practice in the last 5 years? And what do you think has really driven that change?
I think some of the thoracic procedures, because the small space in the thoracic cavity makes it a little bit more challenging to do some of these operations. Even with very small babies, when you're doing minimally invasive surgery in the abdomen, it doesn't feel as small as some of these, 2 kilo babies would make it seem. But in the chest, you're really restricted by the ribs and the actual thoracic cavity. So it does take a little bit more technical difficulty to do some of these operations. So some of the smaller devices that have been created for peds really helps with that, doing things like thoracoscopic lobectomies, tracheoesophageal fistulas, like I mentioned before, doing that thoracoscopically. Um, we do a lot more thoracoscopic internal traction in the last 5 years or so. That's really developed by some of our international pediatric surgeons. So when there's a long gap and the esophagus can't come together, that surgery has really, really changed dramatically in the last 5 to 10 years of how we approach it and how much we're able to get the esophagus, the native esophagus, together and not have to do things like replacement operations, which is a real challenging operation with a lot of complications that come up.
That's so interesting. I feel like there's so many things you can do in kids that you would never be able to do in adults. And I think that's kind of the magic of pediatric surgery. So I think similar to that sort of topic, I think you've also published some things on magnetic compression anastomoses and other device innovations in children. Can you tell us a little bit more about that? I would just kind of love to hear it since it's not something I typically do.
Yeah, that's an area that I find extremely interesting. So there are a couple of real pioneers in this field, like Dr. Harrison, for example, really was one of the biggest pioneers in the US about magnemosis. And I mean, although magnets have been around for a while, it's really been clinically used in the last, decade, I'd say, to attempt to create compression anastomosis. I have been involved or had been involved, I will say, in a clinical study using magnets to create an esophageal anastomosis for esophageal atresia. There was a device that Cook had made that allowed for both the attraction of the two pouches, lengthening, and then anastomosis. Unfortunately, that device was taken off of the market, not for safety concerns, just because of the difficulty in continuing with the FDA regulations and continuing to make that product. But certainly the kind of the idea behind it is still a good one. And there are still types of magnets used clinically, just not that particular one anymore. But the idea, of course, is to create an anastomosis with the magnets rather than a surgical, hand sewn or stapled anastomosis. And there are some other applications. Again, it is difficult with the small size of kids. So for esophageal atresia, for instance, that particular device was only applicable for kids less than a year of age. So to actually deliver the device, the magnets, you need very small devices to do so, and that is certainly a challenge. So hopefully in the future there will be continued innovation in this area.
Yeah. And I guess like in thinking about some of these processes and when you're adopting maybe devices that weren't always meant to be used in kids, like, how do you think about the safety pathway, the IRB approval process, or maybe even the device adoption pathway? Do you feel like there's a lot more barriers because it's the pediatric population? I feel like sometimes that can be more difficult, maybe from a regulatory standpoint.
Yes and no. There is a lot of regulation, as there is for all, FDA processes. There are some specific pathways that are humanitarian device exemption type pathways. There are some of the rare disease pathways that can help expedite the process. can help with some aspects of the regulation. But like anything, once these devices are in trials, or FDA approved, they do need a lot of follow-up. And that does take a lot of sort of manpower. And a lot of these disease processes aren't that common. So it becomes difficult to have the numbers to follow this up and the long-term follow-up.
Yeah, I mean, I think another thing we see kind of filtered throughout your journey has been, and this really follows along with what you just said, is this multi-center collaboration piece that certainly with pediatrics, when you don't necessarily have a high volume of these, you really probably have to, do that a lot, especially with looking at innovation. And I think you've had many collaborations like CARES and others that show up repeatedly. What has been your secret to getting multiple sites to collect data, use data consistently? I know at my center, it's very difficult to kind of get over those hurdles of data sharing agreements and things like that.
Yeah. Well, I think you're right. I mean, I think it's probably important in all areas, but particularly in fields in which the numbers just aren't huge for certain disease processes. It's really important to be able to generalize the findings to a bigger population with larger numbers, make sure it's not a single center, a single surgeon. So certainly being a member of these societies like SAGES has really helped my network and ability to find people that are interested in collaborating. And I really do think these multi-center institutional studies have been very important. It's been a lot more, popular and increasing in use in the last, 5 years, I'd say. We have a lot of collaborations now in pediatric surgery that are both society-based as well as are geographically based. And, just figuring out a process of talking to institutions, creating the IRBs, getting DUAs with one center, that's the site PI, and then having everyone follow the protocols. Just kind of keeping a strict protocol of how to do it has been really helpful in allowing us to do that.
That seems so complex.
So much work. It's so much work. I applaud you, and especially given that you've gone from a couple different institutions along the way, and I'm sure you got exposure to each of those. I would think that maybe you've been able to keep a lot of those relationships going at each of those places. Is that a fair
Yeah,
statement? Yeah.
yeah, definitely. Yeah.
So you're not a bridge burner, is what I'm getting. Yeah.
Hopefully not. But again, that is
So I
also
know you're not. I know you're not. I know you're not.
the other
That's
thing
good.
about pediatric surgery that is nice is that it is a smaller field. And, we do know a lot of our colleagues at lots of institutions. So it is fun and easy usually to create those relationships.
Yeah. So I'm going to pivot a little bit and ask you about your MBA. So you completed that in Chicago. And so I sort of wanted to ask about your perspective on business training and how did you feel like that impacted how you led programs or potentially how you think about value quality or even the diffusion of innovation in pediatric surgery?
Yeah, great question. I thought my MBA was really very valuable, specifically in aspects of, how to approach people to, help with projects, creating relationships that maybe are a little bit different than, just the clinical relationships that we're very used to, sort of how to approach it, how to frame it, how to prepare for those type of questioning and getting the resources needed to, really kind of think ahead of time what is needed and how to approach that. Um, those really, and I think those really are the biggest skill sets that I developed from my MBA program.
How did you fit that into your clinic? I'm assuming you did that during your time in Chicago when you were
I did.
there as faculty.
I did. I got an executive MBA, so it was based on people that are already working. So we had classes every other weekend. So it did take a lot of time,
Every
but
other weekend.
every
Oof.
other
Yeah,
weekend.
Bethany saw my
Oof.
face, so I was like, whoa.
Oh man.
So with
Yeah.
call, one of those other weekends, maybe two of the
Yeah.
other weekends, but
Yeah. Yeah. And how it was it 2 years to take
correct, two
2 years?
years.
Yeah. Yeah. Yeah, I would agree. Mine was not as rigorous as that. We did it like once a month, 4 times, over a weekend. And it taught a lot of the same things you mentioned, and I think even more so, especially when you start to see how the administration speaks and how what language they use. You can kind of sit at the table and translate what they're saying, and be somewhat of a bridge to the clinicians in your group or whatnot, just to kind of serve in that role. I felt that to be also quite useful. So for anyone out there who is considering it, I think you have two advocates here that would encourage you to go for it. So
Definitely.
Jenny, go for it.
Yeah, actually, it's funny that you mentioned that because my husband and I had been talking about it recently, just because I think, with how the landscape of healthcare systems and finance has just changed so much. I think even in the last 5 to 10 years, or maybe I'm just more aware of it now, and maybe it's always been like this, I don't know. But it just feels like sometimes as physicians, you have less power over what is happening in your healthcare system. And I do think that potentially getting an MBA is a good way to kind of empower ourselves a little bit to sort of look behind what's going on, sort
Yeah.
of in that C-suite and that close curtain, because I think more knowledge is definitely power. So I don't know if you have to do much more to convince me. Although when you said every other weekend, I was like,
Yeah.
with a toddler, I don't know if that's in
Yeah,
my
maybe
cards
maybe
right now.
wait. Yeah, wait a little bit, but in the future for sure.
Do you think there's I guess this is kind of just knowledge seeking, but do you think there's a time point in your career where it is the most valuable? Like, if you hit this leadership level, like it would be more
Mm.
valuable going forward. Is there like a good time in your career you think that people should consider getting an MBA if they've thought about it?
I do think it is more helpful when you are working on transitioning to a more leadership type of role,
Yeah.
because I think no matter what, it can help at any time. But to really be able to apply the skills like creating a business plan that you might need as a division chief, really understanding what budgets mean, you kind of forget a lot of the details once it's been a couple of years. So to really be able to apply those specific skill sets in those areas might be more helpful when you're really trying for that transition of a higher leadership role.
Yeah, I mean, I forgot within a couple months. So Bethany's retention is a little bit stronger than mine, which is also not surprising. But I would say when you are even in the midst of those transitions, it's helpful because you have the people in your groups that can, sort of, help you with a lot of the questions you might have, and so I think there is a sweet spot. But even if it's during the transition, even though it might be hectic. So obviously we're the podcast, the official podcast for SAGES, and I definitely want to ask you about guidelines. But before that, maybe tell us how you got involved in SAGES from the start. I would say that our makeup is not heavily weighted toward pediatric surgeons, and obviously you have your own societies. So what made you be one of the brave few that came to SAGES?
Yeah, well, I was first introduced to SAGES since SAGES used to be the annual meeting was together with IPEG, which was one of
Yeah.
our pediatric surgery societies, an international group that every third year we had our meetings together. So that's how I was first introduced to SAGES, although no longer we don't have this relationship anymore. But I used to go to the meetings and interact with people from SAGES, see some of the sessions. Certainly, our exhibit halls were very different in the years that SAGES was with IPEG versus alone. And, I just was very impressed with how SAGES was inclusive of, all different subspecialties and different practice patterns. And as I got more involved with SAGES, I just really saw that aspect more and more. I really felt that SAGES and the leadership in SAGES kind of rewarded hard work. People who, put in effort into SAGES were able to, move up into leadership positions within committees and then within the society itself. And even after there wasn't this collaboration, with IPEG anymore. I still wanted to be a member because I really think that I got a lot out of being a SAGES member. And the more I, involved myself within the SAGES society, I really did feel that aspect.
Well, I mean, I can speak from experience having worked with you over the past couple of years that your leadership has been exemplary within the guidelines committee. And I have just really, really benefited, as have I think pretty much everybody on the committee who's worked with you. Hats off, and we're the better for you being as part of Sages, and I am for sure. So really appreciative of your leadership. I've learned a lot from watching you lead.
Well, thanks so much. I do think that the guidelines and I will say also a lot of the other educational components of SAGES has been, very impressive and I think really important in the field of surgery, and medicine as a whole. And, I think that I've been lucky in the timing and the mentors that I've had in the guidelines committee that we've really been able to create a very rigorous process for the guidelines. And, I think it's really improved over the years. We've
Yeah.
also been very privileged to have funding for fellows in our guidelines committee. So I know that our fellows have been on Sage's Stories in the past to tell what
Yeah.
experiences like. So we appreciate that. But they I think have a great opportunity to network with a lot of Sage's attendings and a lot of publications and see how the process works. But they really really help with getting the work done, which is great.
And just kind of following up, how did you first get interested in guidelines? Like, what led you to sort of join that and then ultimately kind of lead the group?
Yeah, I mean, I think it was just one of those committees that I thought would be interesting because I didn't really know very much about it. And, there was, I guess, an opening in the committee, and I thought this would be a cool committee to be a part of. I wanted to be, more involved within SAGES and thought it would be a cool thing to learn about, to, put work into to create these guidelines that could hopefully be helpful in practice. And so just got involved in some of the actual guideline projects. The GERD guidelines that we published in maybe 2019-ish now at this point was the first guidelines that I was really involved in. And because of that process, I was able to, be more involved with learning how to do the methodology, what we could do better, and a little bit more time with the previous guideline chair, which sort of really helped get me into a position to become a co-chair and then subsequent chair.
Yeah, I love that story, and I actually really resonate with that. And so I think for all the SAGES members listening who are not involved in committees but really want to get involved and don't know where to start, I think the simplest thing is just nominate yourself and join a committee, show up. And I think before you know it, like you're a co-chair, you're a chair of a committee, and then you just get more and more involved. So it's really honestly that easy, which is awesome. And I think for all those listeners who haven't really seen some of that guideline process up close, Can you tell us a little bit more about that process and, maybe what it takes to take a guideline from the beginning, all the way to the end? There's so much work involved, so I'd love to kind of hear you break that down for us a little bit.
Yes, sure. So we've again really worked on this process and made this a lot more methodical and rigorous. We do use the grade methodology for all of our guidelines, and it involves basically a multi-step process in which our wonderful librarian searches. Well, first, sorry, we figure out a topic that we want to work on, and that involves other committees potentially, sometimes even other societies, and then develop our PICO questions, which stands for population, intervention, comparator, and outcomes. So all of our questions are kind of modeled in that manner in which we're comparing one type of intervention, so that can be a surgical technique, that's usually what it tends to be, or other things, and compare that to a different, for instance, a different type of surgical technique. Then the literature is searched to figure out the comparative publications on that particular topic. We do try to limit how many specific key questions we have because we do want to have our process take about a year or so, and not have it be so difficult to actually accomplish. After the literature is indexed, we use some software to screen through it. We have a screening of just the titles and abstracts, and then a more robust screening of the full texts. Then we have to extract certain outcomes out of the data. And then at that point, that's a little smaller list. We have a statistician who helps us with the analysis of all that data. And then comes the kind of difficult part, I'd say, even though that stuff before was difficult, that just sort of takes a lot of work. But the next step is really to convene panels of experts to actually create the recommendations from the literature review. And there is a kind of, again, a multi-step process for how we do that, going through the grade methodology. But that really goes through a lot of different questions about the data, and we're able to create then a recommendation on which we should perform, either the intervention or the comparator. So hopefully that was a whirlwind brief
It was,
explanation of the process.
yeah. I thought that was a very succinct way, and certainly having now been part of two of these with you and doing some of this data extraction, and it is a grueling but very rewarding process. And now I think your list of kind of recent guidelines that have followed this specific pathway is growing by the week, it seems. You mentioned the GERD one, and then but recently hiatal hernia, appendicitis, laparoscopy during pregnancy, colorectal liver metastasis and ablation. Certainly some others. What recent guidelines are you most proud of when you think of that list, and why? And it's okay if it's the HPBA bile duct injury guidelines, which I think are the best, but it's okay if it's a. I don't fish,
obviously
Bethany.
working,
I do not
working with
fish.
Kevin, that's just the highlight of all the guidelines.
No, so
Um,
tell us about some of the ones that you're kind of like, this is one that really has is going to make some impact.
that is difficult to say because, all of these guidelines are like a labor of love and it's hard to pick them out. But,
Which kid is your favorite?
right.
I don't think you're allowed to ask that, Kevin. That's like, I feel like a no-no.
Okay, all right. So, all right, we can skip it. We can skip it.
Well, I will say I am very excited. I don't want to give away too much because since some of these guidelines haven't been published yet, but we have a couple that should be coming out in the next couple of months, that I think are really interesting. And like, for example, one on EndoFlip in surgical preoperative and operative care. That was very interesting to me because that is not something that I use in my practice. And I think there wasn't as much literature as we're used to. So hopefully it will really be able to inform practice. I did think that appendicitis guideline was also very interesting because, I think a lot of times we just sort of practice of how we were taught and, certain, certainly anecdotal things or some literature that we know of, but to really go through all the literature on a topic that has a lot of different studies, I think that hopefully can lead to some impactful changes, or at least a better discussion with families. One thing I will mention too, though, in regards to our process, I would like to highlight that we have really been using patients a lot more in our guidelines process. And there's been a SAGES task force that has really helped with creating a patient database. So I would give a little plug for looking at the SAGES website to either involve any of your patients that want to be involved in the database and be involved within the process, not just for guidelines, other things as well. Or other committees that want to use the database. There is a request form to be able to request to use this process. But I think this has been something that's been a big change for us because we've always tried to take a patient-centered approach to these guidelines and to actually have patient partners weigh into the importance of the outcomes, to our recommendations, additional aspects that we might not be thinking about as the surgeons, I think is really important. And I'm glad that we've really been incorporating that into the guidelines as of the last, number of years.
I
Also,
completely agree. I think that's been a huge benefit, and we're going to include the link to the Patient Partner Network, the PPN, the SAGES Patient Partner Network, in the show notes for any of the listeners who, again, can be sent out to any of your patients. You have a grateful patient that wants to help, that wants to be a part of this. We're going to collect this and really build basically a library of patients who have potentially undergone certain interventions that can then be asked later. It's just a really good way to engage our patients. So we'll make sure that's included.
Yeah, I love that you mentioned it. And I think something you didn't talk about, but that I just know about because of DLPD is even thinking about diversity, equity, and inclusion in some of the guidelines development and thinking about maybe what's lacking from the data or what we don't know. And I think that's also something to point out too, right? Like specifically for hernia, because I'm a hernia surgeon. I think a lot of times when we talk about watchful waiting, what we don't mention is that most of those studies were not done in women. So we actually have no good data for women in watchful waiting for inguinal hernia, even though you would expect that to be the case. So I do think that some of the work you're doing is really relevant because it also sort of points out maybe where the guidelines do not have sufficient evidence to make a recommendation. But I love like what you talked about for this patient engagement piece. And I guess I kind of want to ask you, how do you think bringing the patient voices sort of change the process? Do you think it changes some of the recommendations you make when you're making those guidelines?
yeah, I mean, it's changed a lot of the processes, and I will say we have published our SOP about how we approach it. There's a lot of kind of different methods of doing it, but we've just tried to be a little systematic in how to do it so that everything is the same. It hasn't really changed our recommendations per se at this point, but I do think it helps to highlight what aspects, particularly the outcomes, are of importance to the patients. Again, rather than us just thinking that that's the case, actually corroborating that information and hearing specifically, maybe things like, well, maybe repeated procedures is not that bad from a patient perspective if it means, the possibility of, treating this in a more efficient manner or something of that nature, or minimally invasive, things that we might not have realized. And it's really highlighted some of those aspects that have put a little bit of a different weight on some of the outcomes.
So once a guideline comes out and is published. What is kind of the strategy for measuring its impact?
Yeah,
And
that's a great question. Thanks for asking that. That is something that we would like to do a little bit more work on. We have tried to look at it, and our IT guru, Jason, has actually helped us a little bit with that in the past. We've sort of looked at, people looking at the websites, how they've kind of taken that information into their practice considerations. What we've tried to do from the SAGES side to at least disseminate the guidelines so that, the first step is to get people to read it. You can't really make a change if people aren't actually seeing the information. So we do publish all of the guidelines on the SAGES website, which is available to all members. We do create visual abstracts as well for all of our guidelines. So those are on the website. We do also post them on social media through the SAGES different sites. And so hopefully that helps to engage our members to be able to identify that a guidelines, has been published and that they can take a look at it, even just look at the visual abstract as at least a summary of the guideline. And after that aspect, in regards to specific, changes in practice, we have tried to collaborate with some other committees to try to work on things. Like, for example, we just submitted and published a guideline on bile duct injuries after laparoscopic cholecystectomy and on imaging techniques. And we've kind of discussed with some other committees and leadership things to help teach aspects of bile duct imaging and techniques. So hopefully some of those implementation practice aspects can be addressed.
Implementation is so hard. I think that's definitely the hardest part about coming out with guidelines. And I hate to keep bringing hernia up, but I feel like it's one of the things that we always talk about is like guideline adherence is so poor, and why that is. But to pivot a little bit, like, you mentioned that you have guideline fellows, and I sort of want to touch on that a little bit because maybe not many people know that this is a fellowship spot that you can actually apply for. And so we'll probably link that in our show notes. But as the committee chair and, as a part of this committee, how do you think about mentoring your guideline fellows and some of the trainees that may also participate in the guidelines? And how do you help them sort of thrive and succeed in this space? I feel like there's a lot of work. How do you help them continue to sort of grow, stay on task, and maybe even hold them accountable? I feel like sometimes that's the hardest part, is making sure that, you're continuing to make progress for like a short fellowship duration.
Yeah, so the fellowship is for 2 years. And, I meet with we actually have two fellowship programs right now, one in the US and one that's based in Australia, which has been a wonderful collaboration. But in order specifically, sort of my and the guidelines chair in general relationship, what I do is I meet with them every 2 weeks. So kind of that keeping accountable and keeping on task. I think that's one of the biggest roles that I have. So that, I ask them to create sort of a checklist with all the different steps of the process. And we just go through all the active projects, every 2 weeks and see where they are, see what needs to be done, things of that nature. But in regards to sort of mentoring and allowing them to get as much as they can out of the 2 years, part of that is what I try to do is encourage them to create relationships with other SAGES members. So I like to try to really introduce them to other members, both within the committee and some of the other committees that we collaborate with. So that, a lot of the fellows obviously are trying to eventually match within some type of fellowship. And I think this is another big aspect of the fellowship, is interacting with other SAGES members, and seeing what SAGES can also be helpful for them for the future.
yeah, and if I can just also add my plug for the fellow, I've had a chance to work with the SAGES guidelines fellows, and they're just delightful interactions that have again enriched my days, and especially if it's coming from the Australian side, because it's usually 13 and a half hours later that we're working through this thing. So that guidelines fellow it's their night, it's our morning, and we try to organize these times. I know that sounds like a nightmare to many people, but it's actually quite fun to kind of know what's going on the other side of the planet, in the different hemispheres. So it's been fun. So I would encourage any second, third year resident in surgery who's looking for an opportunity to consider applying. We will put that application, the job description, in the show notes. Our show notes have grown. This is probably going to be the longest show notes segment, but I think we're really putting some good stuff out here. So we want to make sure people have those links. So we're getting close to the top of our hour, but we have a couple more questions. But before we get to our final, we always like to hear about the SAGES the most memorable SAGES moment. We call this the "We Are the SAGES" segment. This happens to be the favorite segment of one Archana Ramaswamy. If you ever run into her, you can ask her why she likes this segment so much.
We are the world. We are the world. We are the SAGES. We are the SAGES. Sing it, everybody. We are the ones who make it bright our day. So let's start treating. Have you had a good time tonight? There's a choice we make. We got a lot more coming. We are dancing.
Okay, I will. Well, I guess I should have done some more homework and listened to some more full episodes before coming on so that I could have prepared a little better. But okay, so although I have been a member of SAGES for many years, I will say I had never attended the last night, affair at the annual meeting prior to 3 or 4 years ago, because I tended to be there for committee meetings and left before the last night.
Yeah, I think I remember you saying, "Should I stay tonight? Should I stay through?" I'm like, "Yes, you should stay. You should stay for once."
Yeah. So I will say, that the night in general was not what I was expecting and was so much more fun than I had anticipated, but definitely the sing-along and participating in the sing-along with our female surgeons was, I think, one of definitely the highlights for me. And I loved the whole thing. And the last night event at the annual meetings at SAGES is super fun, and definitely recommend people attending.
It does make for a longer week. I will say that, because especially if you're coming for committees, it's it's going to be the end. But I think if you can stretch your CME time, maybe add a vacation day. It's usually a Friday, so you're traveling on Saturday anyway. It is definitely worth it.
Agree.
I love that. Yeah, the last night is always, I think, the most memorable, especially if it's the first one you've been to. And so I think, just to wrap it up, Kevin and I have been doing a segment of sort of quick shots, so kind of pearls for SAGES members. And we thought it would be fun to do some pediatric pearls, especially since most of us do not operate on younger folks. So maybe we'll ask you some things that you feel like general surgeons should know when they encounter pediatric cases in mixed settings. So sometimes, for instance, I take general surgery call, I might get a kid that's like 16 or 18, so not like, a true adult, but sort of kind of like on the cusp that you can sort of treat them as an adult. So what are some things that, potentially we should look out for, you want us to keep in mind, when we're operating on some of these kids?
So that's a good question. It's a little tougher in the adolescent age. I think there are a lot of similarities, but I really do like to emphasize the smaller incisions if that's possible. It might be easier to put, for instance, a 12 port in for something, but if it's a possibility of doing a 5 or, a smaller port, I think that's always nice for the kids for, cosmesis and for postoperative pain. I'm a big proponent of that. I think, looking out for these congenital anomalies, like for instance, you might think that it's just appendicitis if someone has right lower quadrant pain and there's inflammation on whatever imaging scan, it might in fact be a Meckel's, which is going to be a lot more common in the peds population than what you're going to see in adults. So to kind of think about things like that. And then lastly, again, we really do like to minimize radiation risks in kids because they have a full, much longer lifespan ahead of them. So with accumulated radiation risk, that's really important. So we really try to, diagnose things with ultrasounds instead of a CT if that can be avoided. So a little kind of more thought of diagnosing with non-radiation type of diagnostic imaging is a big important aspect for us in pediatric surgery.
All right.
So oh, okay. I thought we're gonna go back and forth. So I'll do one, you do one. Okay. So adolescent anti-reflux operation. Ready, go.
Okay. Well, unfortunately, it's a very institutional type of procedure now in terms of, if a institution kind of believes in it. But I think
Okay.
it is an important and great operation for selected patients. And, we do tend to do more full Nissen fundoplications rather than partial ones. I think that's just how a lot of people in the US have trained, but I think it's a great operation if done in the correct patients. But with peds, the other aspect is we have a lot of neurologically atypical patients, and that definitely has a different complication profile. So that needs to be kept in mind.
All right. I feel like I'm totally outing myself as a hernia surgeon this episode, but I always want to ask, like, so for inguinal hernias, at what threshold do you consider putting in mesh, or would you treat them no longer sort of as like a pediatric patient? Sometimes when I see younger patients that are sort of like 18, it's sort of like, do I treat them as a kid? Do like, maybe even a tissue-based repair or a laparoscopic pediatric repair, you're just closing sort of that internal ring versus doing a full mesh repair. So give us some thoughts on that.
Yeah, that's a tough question in that adolescent population. And, we are trying to accumulate some more data, but I personally don't put mesh in kids at all. Well, in this particular scenario, I don't really actually remember how to do that operation. So if there is a patient who, is like a 17-year-old who is an athlete, who might benefit from a floor repair, I would actually refer to an adult surgeon. But, or if I were to like see a direct hernia, which, almost never happens in our patient population, and it's not an indirect, that would be another one that I would refer to an adult. But typically, for patients that are not, weightlifters, just a high ligation is an adequate operation. And then for that kind of patient population, I think you do need to trade off, postoperative pain, possibility of issues with the mesh versus, maybe a potential increased recurrence risk. But we tend to just do high ligations for that adolescent population as well and don't use mesh.
Yeah, I think it's so interesting because sometimes I think at 18 they're just not done growing yet, depending on like who you are. And so I don't disagree with you. I feel like putting mesh in those patients can be difficult because that mesh doesn't really grow as they continue to grow. So definitely some food for thought.
So I'm going to out myself as a HPB surgeon. So pediatric cholecystolithiasis, first approach for you.
Yeah, so that's actually depended a little bit on where I've been institutionally because it's sometimes very difficult to obtain an MRCP or an ERCP preoperatively. We are really trying to kind of create this movement to push more to surgery first, and a lot of pediatric patients were really able to clear any stones, just with doing a cholangiogram and flushing, giving glucagon. So, I'm starting to change my practice to do more of that, but it's a little difficult at an institution in which the, GI might be consulted first before surgery. So creating a good protocol and working with the other stakeholders is certainly important for that. But I think there is definitely utility in potentially trying to just clear the duct surgically.
Great. Surgery first. You heard it here first. So, Bethany, I just want to thank you for the work you do in the OR, in the literature you put out for SAGES, and of course for society, the Pediatric Society, and really adult population with all the work that you've put out. So, really a pleasure to have you on the show.
Thank you so much. Go ahead. Thanks
Go
for
ahead, Bethany.
having me.
So we will, I know Jason says awkward. Okay. So if
No,
we got to do,
wait,
we got to do
Bethany,
a
you
better
should say
job.
that again so we could re-record that. Sorry.
Okay, re-record
I feel
that.
bad
Okay.
because I was like,
All right, here, Jason, we're going to cut that out.
Oh, no, we're not.
And
Cut
we're
that
gonna
out.
do, all right, we're going to start, we're going to go back to, okay. And I'll tee it up. Okay. So Bethany, we just want to thank you for all the work you do in the OR, in the literature, for SAGES, and of course for our society.
Thank you so much, and thanks for having me. It was a real pleasure to be on SAGES Stories and to talk to you both.
Thank you.
yeah, I want to echo Kevin's sentiments. Thank you so much for being here. It was so great to have you on the show. I personally learned so much about pediatric surgery and also about guidelines. And I think to our audience, if you enjoyed today's episode, please share it with our colleagues and subscribe wherever you get your podcasts. And to learn more, get involved with the guidelines, visit sages.org and look for the guidelines committee page. And I think Jason will have a lot of show notes to be adding.
Thanks everyone for listening to SAGES Stories. We'll see you next time. And that wraps up today's episode of SAGES Stories. You can view the show notes for any links to sites we referenced today. Visit sages.org for membership information and for the most recent news from our society. Follow us on Twitter at @sages_updates. Make sure you hit the like button and subscribe so you don't miss any future episodes. See you again next time, and remember, you can't spell minimally invasive surgery without SAGES.